Today we will discuss a case about pediatric diabetic ketoacidosis. General case data. Our patient name is Ahmed Kadhim. He is a male, 5 years old. His weight 20 kilogram. Admission date in the last year, 15th of March 2019 in the morning. The main chief complaint for that child was unconsciousness, history of a presented illness. 5 days ago, the mother noticed that the child suffered from enuresis. Enuresis حقيقة هي علامة مع polyuria, and drinks water a lot. A few days later, the child suffered from abdominal pain and intermittent vomiting. Then the child falls suddenly and admitted to hospital. Past medical history, infantile eczema, and past medication history negative, the drug allergy to penicillin, and the family history, the child mother has type 1 DM. Physical examination on admission, soft abdomen, acetone breathe, Kussmaul breathing, loss of skin turgor, capillary refill time about 4 seconds. We can see this method for checking the capillary refill time. If it is elongated too much, indicate there is a sign for dehydration. And there is also anuria, which is also another sign for dehydration. A vital sign for the baby. On admission, he is hypotensive, heart rate, also elevated tachycardia and tachypnea, while the temperature was within the normal range. The laboratory data, according to physical examination and according to the history of the patient, we suspect the case to be diabetic ketoacidosis, so the following lab data was ordered by the physician in the emergency department. Random blood glucose was highly elevated, 580 milligram per deciliter. Urine analysis showed ketone 3 plus and sugar 4 plus. Serum potassium was within the normal range, which is 4 milliequivalent per liter. Serum sodium, there is hyponatremia, 131, while urea and creatinine was within the normal range. Initial treatment in the emergency ward, shoot of normal saline, half pint over 30 minutes, and then starting IV infusion of normal saline, 100 milliliter per hour, and also an infusion of soluble insulin, 2 units per hour. The physician also asked for a DKA chart with the blood glucose level measurement every hour. Ceftriaxone also was added, which is nearly added to all hospitalized patients in Iraq. And also the physician asked to add this statement null by mouth, even if the baby slightly become conscious. In the night tour for the same day, the patient become conscious, muscle weakness, suffer from muscle weakness, so potassium level was ordered again and found to be low. Potassium 10 units per liter of fluid was added. At that time, random blood glucose level was 220, so fluid was changed to 1/5 dextrose saline instead of normal saline. Temperature also normal, and the baby still suffer from tachypnea and tachycardia. 2 days later, the baby stabilized and transferred to general pediatric ward. At that time, the child was conscious and still suffer from polyuria. The following data was obtained. Serum potassium slightly elevated within the normal range after it was decreased in the night tour, as we remember. Serum potassium within the normal range now after correction of diabetic ketoacidosis. Fasting blood glucose elevated, still elevated, 200. and urinalysis show just 1 plus of ketone. Treatment in the general ward, insulin mix start 6 units in the morning and 4 at night. Then the measurement of random blood glucose ordered 4 times daily instead of once every hour. 1/5 dextrose saline, 2 pints per day. Healthy eating because the baby is not unconscious now. Ceftriaxone and paracetamol syrup as newly addition. Laboratory data in the second day in the general ward. Fasting blood glucose 300, which is elevation from the previous day. Serum sodium is lowered, which is hyponatremia, and serum potassium still within the normal range. Let's think of the treatment and the major problem in this case. So why our patient admitted to hospital in unconscious state? First of all, we need to know diabetic ketoacidosis pathophysiology. In diabetic ketoacidosis, the baby suffers from type 1 DM, which has sudden onset. We don't know whether the baby have DM or not, so eat normally, don't take insulin. With insulin deficiency, there will be elevation of blood glucose. No suppression for lipolysis, so an increase in blood ketone. An increase in blood glucose, because as we know glucose, osmotic agent, so there will be osmotic diuresis. So there will be fluid and electrolyte depletion. On the other hand, blood ketone when elevated lead to vomiting, as we see in our case. There is abdominal pain and vomiting. The baby suffers from these symptoms. Vomiting lead also to fluid and electrolyte depletion. On the other hand, elevation of blood ketone, ketoacidosis leading to acidosis. All these, fluid and electrolyte depletion plus the acidosis, lead to cerebral edema and lead to sign for unconsciousness. This is the main problem in this case. So why the physician start with sodium chloride or normal saline fluid shoot? Is it necessary before we start insulin therapy? Yes, actually it is within the normal guideline to start IV fluid before insulin therapy, because there is a greater risk for cerebral edema of patients who receive insulin within the first hour of treatment. Why? Because when you give insulin, lower blood glucose level, so change in osmolality, and in this case brain cell have adaptation to certain level of osmolality, so there will be shifting of water inside brain cell, so we get brain cell edema. So is normal saline the most suitable resuscitation fluid? Can we start with the glucose water? Can we start with hypertonic saline? Actually the answer is yes, normal saline is the fluid of choice. Why? Because if we start with hypertonic saline, we cannot. Why? Because the patient already has a huge amount of glucose in the blood. This huge amount of glucose lead to hyperosmolality, so it's not a good choice. On the other hand, if we start with the glucose water, it's not a good choice because it's hypotonic fluid, despite it is isotonic fluid, but inside the body all glucose will be consumed, so it will be considered as hypotonic fluid, so it will worsening brain cell edema. The fourth point, do we think that 100 milliliter per hour of fluid is sufficient for this patient? To know the answer for this question, we need to know how much fluid we need to give to the patient to correct the deficit. So how much deficit the patient has. Actually we can measure the deficit either by measuring the weight loss, if we already know the baby weight before the case and on admission, but it's usually difficult, so usually depend on the range according to dehydration severity from 5 to 10%. For moderate dehydration we can choose 5%, and for severe we can choose 10%. So actually If the patient have severe acidosis or compromised circulation, initial resuscitation need around 10 to 20 milliliter of isotonic sodium chloride. Can be administered over 30 minutes. Other reference mention 1 hour. It's okay. In our case, it's acceptable. Let's see. After resuscitation, with the fluid shoot, we need to correct the fluid deficit over 48 hours by providing normal maintenance fluid together with the calculated deficit. The maintenance fluid can be calculated from the following criteria. 1 kilogram. For the first 10 kilogram we need 100 milliliter, and for each kilogram from 10 to 20 we need 50 ml, and 20 ml for each kilogram above 20. Because the baby has 20 kilogram, so we need around 1500 milliliter. To calculate hourly infusion rate, we need also to subtract the initial resuscitation fluid bolus, the fluid shoot, from the total calculated deficit. The fluid deficit, because the baby has severe dehydration. How we know severe dehydration? Because we have late capillary refill, 4 seconds, anuria, hypertension, and loss of skin, turgor. You can see in this table any baby with hypotension, capillary refill more 3 seconds, loss of skin, turgor, anuria indicate severe dehydration, and children usually consider around 10% fluid deficit because 20 kilograms, so we need around 2000 milliliter. This is the fluid deficit, and the maintenance for the baby around 1500 ml. Initial resuscitation, as we said, between 10 to 20. 10 to 20, around 200 to 400 ml. In this case, they give 250 ml, so it's acceptable. Total deficit, 2000 minus 250 ml, so we get 1750 ml. This should be given over 2 days. In the first day, the dose is 103 ml per hour, which is near to 100 ml per hour. Accepted. Why? Because, as we say, 1750 over 2 days. This we need to be added to the normal daily maintenance. So in this case, we get around 2375. This should be divided by 23 hours. Why 23 hours? Because within the first hour we give the normal saline shoot. And the second day we need around 99 ml per hour, which is also near to the given dose, which is 100 ml per hour. Again, the same calculation, just we need to divide the total amount of fluid by 24 hours in the second day. The FIFO problem, why the physician decided to shift to 1/5 normal saline. Actually, to correct any fluid deficit, we need to start with normal saline until blood glucose level fall to 250 or 300 milligram per deciliter. At that time, we need to start glucose containing fluid. Which are they? Either 5% glucose in water or 5% glucose with 9% saline. This allow continued administration of insulin, which is often necessary to correct the residual ketoacidosis. Actually, the physician start the shift correctly, but the choice of a fluid is wrong because we start with 1/5 glucose saline, maybe because of the availability in the hospital. On the other question, why the patient develop muscle weakness? As we know, muscle weakness is one of the symptoms for hypokalemia. So, initially the patient have normal or elevated level of serum potassium. In this case, we have normal potassium, which is around 4, normal between 3.5 to 5 milliequivalent per liter. Actually, the children with DKA have a total body deficit for potassium, but normal level. This normal level due to absence of insulin, due to acidosis that shift the potassium into the blood, into extracellular compartment. And again, the total body deficit of potassium results from vomiting and osmotic diuresis. So, how to prevent the potassium level abnormality? Because hypo and hyperkalemia both life-threatening condition. We need to measure serum potassium initially, but in this case, we don't measure potassium rapidly before start the treatment. If laboratory measure of serum potassium is delayed, sometimes not delayed, but the result delayed, as in our case, we need to perform ECG for baseline evaluation of potassium status. As we know, any change in potassium level lead to ECG change. So if the patient hyperkalemic, we not start potassium replacement therapy until urine output is documented. Otherwise, we can start potassium with IV fluid initially. We can see here the dose around 40 millimole per liter. How we can administer insulin? Yes, we can administer insulin IV low dose around 0.1 unit per kg, but IV as IV infusion, which is the most safe and effective method for treatment of diabetic ketoacidosis. IV insulin, only the soluble insulin should be given IV infusion and is compatible with normal saline. To reduce the risk of hypoglycemia, because if we add to the IV infusion, we cannot stop the infusion because we want to continue the infusion of water to correct the deficit. We need to infuse the insulin through Y-site or three-way connector into the same intravenous line. Unfortunately, the Y-site connector is not widely used and not highly available in Iraqi pediatric hospital. This is the method we can administer insulin by Y-site and the drip of a fluid on another site. For this method, we can prepare 1 unit of insulin per ml, for example, by mixing 50 units of insulin with 50 milliliter of sodium chloride or normal saline. Again, we can administer insulin subcutaneously, 0.1 unit per kg, preferably using rapid-acting insulin like insulin Lispro or Aspart. But this method is not suitable if the patient has peripheral circulation impaired or severe hypotension. What is the goal of IV insulin therapy? We need to lower blood glucose, but not more than 90 mg per deciliter and not less than 36 mg per deciliter. If more than 90 mg per deciliter, this rapid shift also leads to cerebral edema. So in this case, we need to reduce the dose to 0.5 unit per kg per hour instead of the original, which is 0.005. This is wrong. 0.005 unit instead of 0.1 unit per kg per hour. If blood glucose fall below 120 mg per deciliter per hour, so in this case we can continue with the lowest dose of insulin, which is 0.005, not 0.5 units per kg per hour to avoid ketosis, while increasing the concentration on infused glucose to prevent hypoglycemia. Increase from 5, for example, to 10 and even to 12.5%. Why the patient develop hyponatremia in general ward? You can remember the patient initially was less than 135, then 136, which is within the normal range, and then the concentration dropped to 133. Actually, maintenance fluid is the major problem in this case. Maintenance fluid should be continued with dextrose saline until the child is eating. We remember the child in the general ward can eat according to the physician advice. IV fluid can be stopped 1 to 2 hours after substantial consumption of oral fluid without vomiting. But the physician continue to give the baby 1 liter of fluid per day of hypotonic fluid, which is the main cause for hyponatremia. This is one of the major problems, not in this case, but in Iraqi hospital, at which most patients receive excessive and irrational amount of IV fluid. The last question, is it a good choice to shift the baby from DKA insulin therapy, which is, we said, IV infusion, to twice daily insulin regimen? Actually, all patients newly diagnosed and those who are critically ill are in need for intensive insulin therapy, which is more flexible. We can adjust the dose in each meal to achieve better glycemic control. While using mixed start, we cannot adjust the dose. This is the major problem in our case, which lead to elevated fasting glycemia in the second day in the general ward. This is some of the reference, and thank you for listening.